It's my pleasure to introduce our first speaker, Dr. Walter Busutil. Now, Walter qualified in medicine in Manchester in 1983, joining the Royal Air Force as a medical student cadet. He served for 16 years and qualified as a general practitioner and consultant psychiatrist. He was in the team that rehabilitated the British Beirut hostages and was instrumental in setting up rehabilitation services for Gulf War I combatants suffering from post-traumatic stress. He left the RAF in 1997 and set up tertiary adult general adult and forensic psychiatric services for adult survivors of sexual abuse suffering from complex post-traumatic. Since 2007, he's been the Director of Medical Services to Combat Stress and has led the development of clinical services, including residential, outreach and community programs, nationally expanding clinical capability, attaining national specialist commissioning for the intensive treatment program in 2011. He's active in the media campaign and encouraging statutory and national health services to be set up for veterans' mental health. He has published and lectured internationally in the PTS field. Ladies and gentlemen, please introduce Walter.
Thank you, sir. Thank you. Well, good morning, everybody. It's great to be in Australia again. First time I came in 2001. Wal Hall, who's here, who was the head of psychology, just handed over, saved my life in the DVA car park. I almost stepped on a funnel web spider's nest. I didn't know what a funnel web spider was, but I obviously found out later on. So thanks for that, Wal. And Wal's here in the audience with us. And I think Wal's involved in this fantastic charity, Stand Tall, which really is very impressive. Now, I work for a charity, and I certainly never intended to start working for a charity. It's not a career move that I anticipated at any time in my life. But actually, working for a charity has very big, exciting moments because you can actually innovate quite easily. But obviously, money is always a problem, so it's very difficult to plan clinical services without actually having the money in your budget. So you've got to be extremely careful. I'm very fortunate to work in a team. I'm not the chief exec. We have a chief exec. We have a whole infrastructure, which we'll talk about a bit later on. But I'm extremely fortunate to actually have been there at the right place and at the right time and doing something that really is worthwhile. So Combat Stress is a national charity. We've been around since 1919. We are formally known as the Ex-Service Mental Welfare Society. I think that's quite relevant, really, just for today's kind of introductory slides. We are the largest mental health provider in the UK. The National Health Service commissions us for some of our programs, but 66% of our income comes from pure fundraising and charity. And our turnover when I joined in 2007 was £4 million. And in 2015, we spent 17 million. Last year, we spent about 19 million. And we're trying to cut back on spending because it's extremely difficult to keep in the black. And we've used quite a bit of our reserves. So we're looking at our services again this year to see whether or not we can get better bang for buck, as it were. We have around 3,500 veterans who are actually receiving clinical help at this point. We've got another 1,500 who are kind of on our books, but they're not active, as it were. But periodically they'll dip into clinical services. And roughly we get around 2,500 new veterans coming in for help every year. About 2 or 3 years ago, we had a huge increase in numbers coming forward. Over the last 5 years, we've had a 71% increase in numbers coming forward. And that's mainly Afghanistan and Iraq veterans. And we'll look at a referral study over the last 20 years or so in a few minutes. Of course, we started with wives and good women and girlfriends in 1919. The suffragettes were very instrumental setting this charity up. And really, it was about ex-service mental welfare. There were mentally broken ex-servicemen who were being held in asylums, And that was a big scandal for a time, but of course everything waxed and waned for a long time. I think we heard yesterday from Sandy McFarlane about people's personality and the kind of lack of resilience that people felt, that people with shell shock, soldiers with shell shock, were suffering from. And at last, at some point in the 1930s, the Queen Mother became the patron of combat stress. Before that, there was a lot of media campaigning that really even lost royal patronage for a while. So things got really hot, as it were. And these things still happen, and certainly I've experienced some of that as well. So combat stress had a whole variety of things. There was basket weaving, there were piggery farms. We collected tomatoes and made electric blankets. So this charity has specialized in various ways over the years. And before 2007, it was mostly respite care. There wasn't much of a clinical service. And we had some residential homes as well as treatment centers, or centers where you'd go to for a couple of weeks at a time for respite. There was usually from the care home that I'm currently working from. There were booze cruises to France to buy your booze. There was a bar, and it was just respite. There was not very much going on. And there was this mental health welfare, and they were. This was run by ex-military officers who really just did some assertive outreach, went to veterans' homes, made sure they had food in the fridge, made sure they applied for their pensions. And the system really carried on until maybe 18 months ago, when we decided that another charity could do this and we could employ occupational therapists instead in the community. So this, for example, was a clinical audit. I've missed people's names out there. This is 1987. This is presumably somebody, some of the patients who were residents in 1987. And this would be a clinical audit. We'd call this perhaps an attempt at a clinical audit. State of health, mental, poor, moderate, poor, physical, moderate, good. So there wasn't very much clinical stuff going on at all. And we had this big investigation, which was a report from the Health and Social Care Advisory Service, which was an international scrutiny of what combat stress was doing, because we were getting money from war pensions at that time. Professor Mark Creamer from Australia was involved in that. And really, it was a pretty difficult and damning report on the lack of clinical service that combat stress was actually delivering. We were literally just doing 3 respite care homes, a few welfare officer, very little formal clinical assessment. The needs were not fully identified. There was one audit of 100 patients that a visiting psychiatrist had conducted off his own back, with a really hint that most of the patients had PTSD, depression, and alcohol disorders. There certainly was no therapy, no community services, and no clinical governance. And at this time, there was a lot of campaigning in the media. 2005, 6, 7, the war in Afghanistan for Britain was getting very, very hot indeed. And I was persuaded in 2007 to leave a very nice job as medical director of a very big private ladies' forensic hospital, medium secure, where we'd set up a huge dialectic behavior therapy service. We'd cut down the number of self-harming incidents to very, very low levels. We had a DBT program which was running for about a year, and then you'd do a trauma-focused psychoeducation, cognitive behavior therapy program for another year. And actually, you could get better even if you'd been incarcerated in a medium secure hospital for quite some time, and would step people down. So it was quite a successful therapeutic milieu. And unfortunately, I never published that work, but it really was cutting edge and was very, very pleased with it. But on the 9/11, so this was many years before 2007, the chief exec of Combat Stress came to see me and Gordon Turnbull, who was my boss in the Air Force. We'd just left the Air Force and set up a traumatic stress service in the private sector, because the NHS had no traumatic services at all in the 1990s. So this was around 1990, from 97 to 2004, I stayed there. And he asked whether we would ever consider setting up clinical services at combat stress. And I've known a lot about combat stress as a junior psychiatrist in the Air Force. I did a lot of free assessments for Far Eastern prisoners of war. They were really interesting old guys. Suddenly the British government decided in 1988 that FIPOs were entitled to, or might be entitled to, some kind of compensation. And not only did they have horrendous physical diseases with lots of parasitic infestations still present. These guys were in their 70s and 80s, but also they had rip-roaring PTSD. We published quite a lot of our findings, but we had nowhere to refer these old guys to, and we referred them to combat stress. But of course, it was not a clinical service. So on 9/11, Toby Elliott came into my office and said, look, we want you to set up something clinical, a clinical service at combat stress. We said, look, there's no war. There's no reason to, there's no money, and there's no will. And then one of the secretaries came in and said, look, the Twin Towers have come down. And we turned around and said, actually, now we must be at war. There's going to be a problem with veterans. And if you really get the funding and there's a real will from the Board of Trustees, we'll see what we can do. So in 2007, I got a call from Toby, and he said, look, we've got the money, there is the will, will you come? And that was my brief, to set up cutting-edge clinical services and anticipate really that many veterans would need these services for veterans. And some friendly advice from Chris Freeman from Edinburgh, a great friend of mine. You realize that working for a charity and setting up services for a charity could be professional financial suicide for you, Walter. We're glad it's you, but don't do it. And then a very senior doctor in the NHS who said, well, actually, the NHS will just pick up all these guys, just as we do for other uniformed services, and will never fund any kind of specialist, bespoke clinical service, certainly nothing run through charity. And, it was unbelievable. The attitude and the ignorance was unbelievable. So I did join Combat Stress in 2007, and I was the first doctor ever to be employed full-time for the organization. We had no real clinical staff. We had no psychology, OT. We had a few nurses, a couple of psychotherapists. I replaced the doctor who'd visited maybe half a day a week, and we had another doctor who visited another treatment center half a day a week, and that was about it. And what I set out to do then is to try and see whether this was going to be possible. Of course, the first thing I asked for was where's the clinical governance framework, and there was none. What about clinical audits? Do we know what's going on here? Who are these people coming forward for help? What are their needs? And I found that audit of just 100 patients. And then I knew that if I was going to set things up, we'd do it properly, we'd need multidisciplinary teams, we'd need a phasic treatment model. If it's trauma we're going to deal with, and that's what we were going to specialize in. And of course, we needed a mix of residential and community, because that's what works, and that's what the Australians have shown in the literature and the Australian and National New Zealand journals, all the papers. And of course, when I was in the Air Force in 1991, we met Mark Creamer because he came to see us, and he looked at our program, and our program had a mix of residential and community. We had a trauma-focused component to the residential, and then we had education and skills training. And really, for me, it was pretty obvious what we needed to do. And of course, the other thing in my brief was that we were going to lose the funding through war pensions, because war pensions decided they wanted to pull the funding for combat stress. So we had a real disaster on our hands. And that's quite tough when you're coming from a kind of lucrative private sector job to actually start from scratch with very little. So the document, in fact, I wrote on holiday. I'm from Malta originally, and I joined Combat Stress in June. In the August, I took my family to Gozo. I recommend Gozo. It's a fantastic island next to Malta. And I sat in a 5-star hotel, which I paid for myself, and I wrote this document, which included all of these components. And then what I did was I leaked this document to NHS England, NHS Scotland, NHS Wales, and NHS Northern Ireland, and then I leaked it to the MOD, and we presented it to the Board of Trustees. They approved the plan, And then one day I was in a meeting in Scotland, so very soon after, in September 2007, and this very nice lady, Denise Coyer, said to me, "Do you know who I am?" I said, "I have no idea who you are, Denise." She said, "Look, I'm the medical director for Scotland. I've read your report, and we want to help." And we had a foot in the door, and the Scottish Health Service started to look at ways and means to deal with the veteran issue in Scotland. And they started to fund some of our services. And then the NHS England as well kind of looked at things more sympathetically, and things moved on. So without kind of going through all that history, now we have quite a reasonable structure. Prince Charles is our patron and took over from his grandmother. We have the ex-Chief of Defence Staff, General Sir Peter Wall, as our president, Chairman Lieutenant General Andrew Graham. We have a board of trustees, chief exec, directors, regional operations directors. We have a treatment centre managers, we have a clinical governance manager, and we have a community substance misuse manager. So we've kind of got some kind of structure. We have subcommittees with clinical governance really there robustly in the centre of what we do. We have a risk and audit committee, fundraising, and finance committee. So we do quite a lot of our own fundraising, but also other charities, military charities, give us money if and when we ask for it, or some of them give us money for specific projects. And at the moment, September 2007, this is what we have. We offer, and we'll talk about this in more detail, peer support, a national helpline with 1,200 calls a month. We do telephone triage with a senior nurse at the end of the phone, a community service, with outreach. Welfare now is delegated to the Royal British Legion. We have community psychiatric nurses, OT assessments. We use now the British Legion pop-in centres. The Royal British Legion historically has had clubs and basically pubs in various kind of remote areas where veterans would congregate. But recently they changed their policy, and they've set up in the high street walk-in centres where, as a veteran, you can get any information and help regarding welfare, housing, finance, but also we actually now have clinics based in the high street, and they're pretty anonymous. Nobody knows we're really there. We can do groups, so we can do individual psychotherapy as well. And certainly we've seen a surge in senior officers who hitherto weren't really coming to us, coming forward. And I mean colonel and above, and way above colonel as well, and that's really positive. We have a substance misuse case management service, and we'll talk about that in a few minutes. And then we still have residential beds. I inherited 87 beds. We've still got 87 beds. There's no intention to increase the number of beds. In fact, the intention now is to decrease the number of beds as our community gets much stronger. We only managed to get the 42 sites with the British Legion about 18 months to 2 years ago. So that's relatively new. We set up community services in 2010. We had, in each region, we divided the UK into 15 regions. We had community psychiatric nurses and generic psychotherapists who had an interest in family and socially related issues. We've kind of changed that a bit. It's more community nurses now and more occupational therapists. So we'll talk about that in a few minutes. The other thing I set up in 2014 is a research department. When I trained in the military in the 80s and 90s, we had to do research to get our consultant ticket. And I've always been interested in research, but there was so much data coming in at combat stress. There was no way I could carry on doing things by myself. So we've appointed a senior psychologist who's a senior lecturer now, and he's embedded in the King's Centre for Military Health Research, which is run by Professor Sir Simon Wesley, who is just the outgoing president of the College of Psychiatrists. Simon's a great friend of mine, and I trained with him at the Maudsley. And I rang him up in 2007 and said, "Look, Si, you've got to become a trustee of combat stress because we're deeply in trouble. It's the only veteran service where anyone can start to build some kind of infrastructure on to deliver some kind of therapeutic input to all these guys who are going to come back from Afghanistan and Iraq." And Simon's been a great help and collaborator. But actually, we've looked at 3 areas mainly for research. So what are our treatment programs doing? Who is the population? What's wrong with them? What is the problem in relation to their needs? Where are they? Are they living in deprived areas? Where do we need to put our clinics, basically, as well? And what about innovative interventions? What can we do better? And we'll talk a bit about that. So who are we dealing with at this point? So we're dealing with majority ex-army, and a veteran in the UK is somebody who's served for 1 day. So we'll take any veteran who's served for 1 day. They don't have to have served for longer than that, but we'll at least assess them. So mainly Army. We would take Merchant Navy if they come forward. At the moment, we don't have any. We had a few really from the Falklands War, particularly when civilian ships were commandeered to go and fight in that war. Few from the Air Force, mainly medics, a lot of medics, and RAF regiment, particularly from Bosnia. Bosnia peacekeeping was horrendous for them. Royal Marines, very low, rates 3%, and the Navy. Very few females, 3%. The rates of female serving at the moment is between 9 and 11% in the military. 3% reflects what it was like maybe 10 years ago or so. We don't know why not so many females come forward. Maybe it's because our services don't really meet their needs. I did a clinical audit in relation to who these females were, and 1/3 are who you'd expect, the medics and nurses who served in the front line, who got rip-roaring PTSD. But the other 2/3 are ladies who've been traumatized in childhood, or ladies who were sexually harassed while in the military. And we're not kind of cut to deliver those kind of services. The average time from people who leaving the military to come in combat stress is about 12.2 years. And I have to say that our audits have shown that 80% of all our veterans have tried to get help through the NHS before, but for some reason that help hasn't done the trick. So there are big issues about engagement, really, and treatment completion, which, you know, for me, if I'm going to spend 17 million pounds, which we really don't have, that money needs to be spent properly with evidence-based treatments. Having said that, if your service isn't compatible with the culture of the people you're trying to engage, and people don't engage and don't complete, you're wasting your time and wasting your money. Well, it's not my money, it's charitable money, even worse. What we have found with Afghanistan and Iraq veterans is they're coming forward much more quickly than we expected. And this has been kind of a theme throughout the last few years. We published our first paper on that in 2011 or 12. And it's just kept the same momentum, really. So that's really positive, and we'll talk a bit about that in a few minutes. On average, the below 65s are unemployed, half are unemployed and half are employed. So they are kind of a relatively difficult group because many don't feel that they can move forward. Now, just to explain the pension system in Britain, there are 2 kinds of pensions that a veteran can claim. They're both not very generous, but actually they produce different attitudes in relation to your patient. The first is the War Pension Scheme that stipulates if you've been injured mentally or physically before the 5th of April 2005, you can apply and reapply and continue to apply ad nauseum until finally you achieve a war pension through a tribunal, which is a legal court. And you've got to keep going to this court periodically. They'll call you forward to see how well you're getting. And if you're not getting well, they'll leave you with your pension. But if you're getting well, they'll take your pension away. So there's no incentive really to get better for the older guys. With the younger guys, the Armed Forces Compensation Scheme is supposed to be a no-fault compensation scheme whereby you'll get a lump sum if you are injured after the 5th of April 2005, you get a lump sum of money, and very rarely, and it is very rare, you'll get a long-term pension. And for mental health, the rates are really poor. I think the equivalent, if you're not working because of a mental health illness, is the same as an amputation of your arm, where obviously you could go and get a job if you had an amputation of your arm. You couldn't really get a job if you were severely mentally ill with PTSD, depression, and alcoholism. And by the way, alcohol problems are not pensionable at all within the British military, although we know from all the epidemiological studies that at least 13% of guys and ladies coming back from the recent deployments in Afghanistan and Iraq have serious alcohol problems. So it is a big issue. But the attitude of veterans is different in relation to getting better, and that is a problem. That's a barrier to improvement. And very few know that they can actually apply for a pension. By and large, only about 9% of 2,422 ever knew they could apply for a pension. So people don't even know about the system. This is the difference in relation to people coming forward. So Afghanistan, 2 years, 3.3 Iraq, the Balkans, 5.8 years, Gulf War 1, 8.7, the Falklands and Northern Ireland, a long time. And of course, they're a different era and generation. Of course, Northern Ireland, if you've been in the British military in the last 35 years, certainly in the army, you would have gone to Northern Ireland, been posted there, no question. Northern Ireland's a terrible, hidden, nasty little war. It has been. It's a lot quieter now. There aren't any serious things reported in the press. The undertones are there. We know we've got treatment centre there, outpatient-based, and many veterans there. So many of our veterans still live in fear behind bulletproof glass glazed windows in their homes. So it's still a threatening place for some people. So what about people coming forward? I guess you can't see this easily. This is 924 people came forward for help in 2005. This is 2006-07, 994. And by last year and this year, it's been around 2,500. And we've tried to kind of close the barn door a little by doing our triage more slickly to make sure that people who are appropriate for our services get to our services. People who are not appropriate for our services go to more appropriate services. This is our 20-year study in relation to referrals to combat stress. And the red line is Northern Ireland. The black line is Afghanistan. And it crosses over Iraq. And this is only to 2014. The Afghanistan line is carried on going up. The Iraq line is carried on going up. And now we're looking at what's going to happen to Northern Ireland veterans. Of course, some guys would have served in many different, more than one theatre of operations. But these are kind of generalized findings. And last year, what we found towards the end of the financial year, this is this April, that Iraq and Afghanistan combined have actually superseded the Northern Irish veterans now for the first time. And that is really quite good. It's a good news story, people coming forward. We just wonder how many more there are, and there will be more. The Falklands, oops, sorry, see if I can get back. No, the Falklands has, kind of flatlined a bit. Gulf, bit of flatline. The Balkans, still many new people coming forward as well. So we've conducted a whole series of clinical audits, and I think earlier this week we've published our first paper in our big needs study that reflects 3,500 veterans. And really the findings are very similar to what we already knew. So this is 2014. Dominic Murphy, give him credit. He's our research lead, published this. So, very high rates of PTSD, depression, anxiety, anger, alcohol, problems. This is current alcohol problems. Other audits show that it's 69% for past and present alcohol problems. Highly significant problems with function, a lot of adversity in childhood, and about half of the 52% have been abused in childhood, and a third of those sexually abused. So there's always kind of the complex PTSD over and above the complicated, comorbid post-traumatic stress kind of presentations we're getting, and a lot of significant physical illness. I think we talked a bit about in the sleep lecture yesterday, obesity. My patients are very obese, many of them, especially the older ones. Cardiac problems, diabetes, you name it, they really have it. Of course, we have all the orthopedic problems. So being in the military, give you a Bergen and Plimsolls, tell you to run 5 miles a day every day. for 5 years, your ankles, knees, and hips are going to get, and lower backs are going to get into trouble. So we also published a social deprivation study, and we compared veterans in areas to civilians in living in the same area in relation to housing, access to general mental health care, access to general physical health care, financial income, access to shops, and all that kind of stuff. And we found that actually our veterans are much more deprived, even if they live in fairly modest areas, good areas, much more deprived than their civilian counterparts. And Scotland's got more of a problem than it's Wales, England, and Northern Ireland. And we were surprised about Northern Ireland because the kind of map there is quite odd. This really reflects the fact that the government in Northern Ireland is pumping a lot of money into the social infrastructure, but nothing or very little in relation to the mental health structure. Because the government in Northern Ireland wants to treat both sides of the divide. There are only a certain number of expert trauma specialists in Northern Ireland, and it's very difficult to have ex-IRA and ex-military in the same waiting room. Some clinics have a Monday for ex-IRA and a Tuesday for ex-military, but that doesn't really work either. I have quite a few clinical staff now, which is quite good, and I must say I really ate humble pie when the occupational therapists came fully on board. We had 6 before 2015, when we kind of really boosted up our numbers. Occupational therapists are good at motivating people who cannot do trauma-focused therapy and won't engage in it to looking at ways of coping and actually getting into the workforce. And I think that's been a big revelation. We haven't published their outcomes, but we are looking at their data at the moment, and we will be publishing, and I'm sure we'll be sharing these findings with Phoenix and other organizations here. The triage nurses do a good job as well, and that's really sped up our kind of waiting times. So it's triage nurse first, and then within 48 hours, the individuals discussed in a multidisciplinary team meeting. So that's pretty good. Our addictions nurses have done a very good job, and we'll talk more about our case management service. And the research side's done well. I mean, in the last 5 years, for a small charity, this isn't bad. We've published 31 book chapters and peer-reviewed papers, which is pretty good. So just to kind of reiterate, these are the services we have. The Canadian OSIS model is what we've chosen at this point in relation to our peer support. It's currently rolling out across the UK. We started it at the end of last year. We don't intend for our peer support service to be a clinical service. We intend it to be a service that people go to after they've finished their treatment with us. People can, of course, come back and dip in and out, as it were. There is supervision, but it's really kind of not supervised from a clinical point of view until there is almost a crisis, as it were. It is run by employed people, about 5 or 6 employed people, but the rest of it's run by volunteers. We'll have to see how it goes. I don't know yet, and we're collecting data on that. We're moving our telephone triage nurses into the same building and the same room as our helpline, so that our triage, our front door, is really quite robust. The helpline would take maybe, well, it says 1,200 calls a month. About a quarter of those would be kind of very clinically relevant, people who really need clinical input. About a quarter would be welfare, general questions. Then some would be crisis calls. We've had quite a few suicidal veterans that have needed help right away, and we'd ask the local NHS community mental health crisis teams to get involved straight away. So really, if you were a GP or you were a wife or good woman of a veteran or a veteran, you could phone our helpline, get yourself referred quite easily. You'd get to have a conversation with the triage nurse within 48 hours. Your case would be discussed probably that week. In the MDT, that would be kind of headed by a senior psychologist, a psychiatrist, an occupational therapist, and a community nurse. And then you'd be farmed out either to a community service or else to an outpatient clinic or else to another service if you didn't need combat stress or our substance misuse, case management. And very few then would end up in a residential program. And we also have a rehabilitation well-being break center program. And this is quite an interesting way of working. This is kind of a bit more occupational therapy than an outpatient or community treatment. And we'll talk a bit about that in a few minutes. So we know where our veterans are. We've done big mapping exercises. We've done the social deprivation study. We've got a lot of data from our needs study. So we can actually plug our clinics and put our clinics and where the majority of our veterans are going to be. Of course, there'll be outliers, and we're looking at telemedicine and other techniques really to reach out to those veterans as well. This is a pop-in centre. This is in Birmingham in England. It looks like an office. You can go in, have a chat, or else you can go in and see one of my psychologists and get some psychotherapy. So people like this, and it's really ideal, and the time can be set for when people are free from work, so after work or lunch times or whatever. So let's talk a bit about the case management service. So I wrote a paper on what the military and the NHS should do in conjunction and collaboration with charities in relation to alcohol and veterans. And really the center of this was an addiction specialist doing case management. And this is what we've been funded to do. The NHS and the MOD are not involved really in this plan at all, which is a big disappointment because the MOD buys beds from the NHS for their acutely unwell serving personnel, and these beds are spread across the country and they're always empty. So I could have done with those beds to do detox. You know, we now have a scenario where our addiction specialist is linked into the statutory detox service across the UK. We have 11 pilot sites. It's not across the whole of the UK at the moment. They get the detox and there is psychoeducation in relation to addictions, and maybe they see an addictions psychiatrist as well, get their medication sorted out, and then once they're finished there, they're herded back into our clinics or an NHS clinic, depending on their underlying mental health illness, if it exists. And this is quite a good model, really. So this is an audit of around 650 veterans. The point here, I think, is that about 90% of the veterans actually engaged in the service. Now, most addiction services have an engagement rate of 30%, so that's pretty good. So we're doing something right, and you know, Combat Stress is well recognized in the UK as the leading mental health charity. So the badge, you know, just being badged Combat Stress is a big deal. We also kind of found that around 50% of veterans do have an underlying mental health problem. They're not kind of all alcoholics and that's all that their problem is. They're a slightly different bunch to the guys coming to us because not all of them have PTSD. Mostly these would be depressed and mostly that have anxiety disorders, but not necessarily PTSD. And I think the levels of actual operational service are less than the ones that actually come to Combat Stress through the usual means, as it were. The other thing that was part of the deal here is that we wanted to do a lot of education in the addictions field, and we have done that, and that's pretty useful as well. So I'm very pleased with that. So our treatment centres are across the UK. One's in the Midlands, in Shropshire, the other one's in Ayrshire, in Scotland, and the one in Surrey, where the top bit of the building actually is our headquarters. That's the mansion there, and that's where I work. Pretty nice place. That wasn't there when I arrived, nor was that. The chief exec of Help for Heroes, a big fundraising charity for veterans following Afghanistan, came and visited us, and he noticed one of his senior NCOs was a patient of ours, and he said, well, what the hell's wrong with him? He's a very robust guy, he's decorated. I said, so it can affect anybody. And he had a chat with my chief exec and said, look, I want to make a donation from Help for Heroes. How much do you want? And my chief exec came to me and said, I'm going to ask for £350,000. I said, no, you're going to ask for 3.5 million, because we need to have rooms and proper services for veterans, and we need to not do any group therapy in television rooms anymore, where people then, are triggered just by being in the same room trying to watch telly later on at night. We need a demarcation of where people work, where people sleep. It's a 9 till 5 program. It's busy. It's manualized. All the programs are manualized 9 till 5. You go to work and then you go home. And so we did get 3.5 million for this center, which is good. We have good facilities. We can run about 6 or 7 groups at the same time in group rooms, which is great. So we can have a whole variety of programs going on. We have art therapy in each of our treatment centers as well. We've got an occupational therapy service in each of our centers, which is pretty good. We get some famous people. He's famous. He does Bake Off. Do you get Bake Off here? Yeah. No? Okay. Well, that's a different version, yeah. He's our Bake Off chief, but that's a snap, because I didn't know the cricketers very well, actually, on my table yesterday. Bit embarrassing. We've got a poetry corner as well, which is good. We've got some areas where people kind of remember their friends who died. We've got a gym in every treatment center, which is good. And our chronic disease management model is a phasic treatment model, which is kind of standard trauma work, which you'll all be familiar with. We prepare people and stabilize them in such a way that they feel safe to be able to disclose what's happened to them during one-to-one psychotherapy, and we have a rehab stance throughout, and then we try and make sure people don't relapse. So that's really very straightforward. Medication's always difficult. We remove a lot of medication, our psychiatrists do. We take, a lot of the veterans come with a whole host of different medications. Many have chronic pain, so all the codeine-based medications are not very good if you dissociate, and you really want somebody in the room if you're going to do your one-to-one therapy. We tend to use SSRIs a lot, first of all to treat depression, because that's commonly present, but also to treat some symptoms of PTSD if necessary, and we use mood stabilizers quite a bit as well. So our programs, these are all mostly 2-week programs. So stabilization program is based on DBT. We haven't published our outcomes, but we're going to. That's a pretty reasonable program for people who have emotional dysregulation. A transdiagnostic program is a program for everybody. They come and just get some skills training. Diagnosis isn't important. Anger management, we've just published, and we'll talk a bit about our anger management program. Then we have our intensive 6-week program, which is based on the Australian model now, and we do some individual trauma-focused work as well. And then the recovery and social reintegration program, which we'll talk about, I think, just now. So what we do is we borrow the Royal British Legion hotels. So the RBL in England has 4 hotels across the country. And if you're a veteran and you're not very, very rich, or a serving member of the armed forces and not very rich, you can take your family on holiday free of charge every 2 years. And in the down season, so from about end of December to the end of March, we were given these hotels if we wish to use them, and we send our occupational therapists primarily and some nursing staff, and then veterans and their spouses ideally, to do behavioral activation exercises and various psychoeducation groups in a non-clinical setting. And what we found is that they actually move away from the sick role, especially for the legacy, the older veterans. This really works well. They don't get cured. We're not expecting a cure, but if function improves, and really function's more important for me than symptom reduction in a lot of these guys who've been ill for so long. This is our 6-week intensive program. This is my salami sandwich and the meat. in the sandwich is the individual trauma-focused CBT. Very high completion rate. So our stabilization phase is extremely important to prepare people and select people for the program and do it only when they're ready rather than set them up to fail. The program is standardized, manualized, properly supervised. It's 9 till 5. There's staff training, homework's given out of hours. People access the occupational therapy department to do group projects. There are family days for psychoeducation for close family members. And we make sure through our OT that they have access to ideas in relation to work and work retraining, and we work in collaboration with various other military and statutory organizations. And everyone gets a nurse key worker. This is the content of the psychoeducational group, so it's what you'd hope and expect, understanding PTSD, principles of CBT, sleep hygiene, etc., information about medication. And then the skills training, again, what you'd expect. There's quite a lot of mindfulness that goes on, how to manage anger. And then there are art therapy sessions. Art therapy is quite interesting in that I think we're publishing a book this year, and we've published a few papers, and we work with Walter Reed, in collaboration, Walter Reed in Washington. It really does engage veterans who can't otherwise engage or verbalize anything. So it's quite a useful means to get people talking, at least. We published our first paper in the BMJ. This was a 6-month follow-up. And, there was an 87% reduction in PTSD symptoms, which was maintained over the 6-month period. So that's not too bad. And we had a high completion rate, which I think is pretty good. Our second BMJ paper was the 1-year follow-up, which showed, I think it's the second line, at 12 months, the effect size really wasn't not different. And so the improvements actually were maintained over the follow-up period, which was pretty good. And Mark Creamer, in fact, did this comparison for us. The comparison between other services across the US and Australia is pretty good. So at least we're not wasting anyone's money, and at least the outcomes are pretty robust and good. We published 2 other papers in relation to post-traumatic growth. Now, I know post-traumatic growth is a bit kind of fluffy, but actually it does define things like, how are you getting on with your family, how are you getting on with a relationship at work, what's your attitude towards life, what's your attitude towards your future. And we found good evidence that this 6-week program actually improves post-traumatic growth and people's attitudes. We did another study looking at predictors as to who does best on our 6-week program, and we found that if you're very anxious or you dissociate, then your outcome will be not as good as if you don't dissociate or that you are anxious. So it's quite important, really, the stabilization phase to identify and then address veterans who might have these characteristics. We looked at the partners of people attending this program as well, and what we found was that they had high rates of depression, anxiety, and PTSD, and alcohol problems compared to the the England Morbidity Survey. I think this was 2015-ish, where really these rates are very low. A lot of functional impairment as well, and we also found that it was worse if they weren't employed or they were actually then living with the veteran partner, being ex-military themselves, and having children living at home kind of was relevant in relation to alcohol problems. We also found that they were too embarrassed to seek help, and these didn't meet clinical criteria for anxiety, but these did. So the more anxious you were, the less likely it was that you were going to go and seek help. Now, combat stress is not really kind of rolled out to treat families. It's not in our articles, it never really has been. But we feel it's very important that the family is looked into, and B, that many spouses and probably children need treatment. So we are doing another study looking at an input which is primarily psychoeducation program for spouses, which we'll talk about a bit later on. This is our anger management program outcome. It's a 2-week residential program. We have exclusion criteria, ideally no traumatic brain injury, but we'll talk more about that in a minute, or personality disorder, no one using alcohol at this point, or substances, a closed group. 25 hours of groups, 20 of them are CBT or DBT, and then occupational therapy and art therapy as well. Individual sessions only 5, daily guided relaxation, and it's a multidisciplinary team approach. So it's pretty good. You don't have to have a clinical diagnosis to attend this program. You've got to be angry. And we know that combat makes people angry. We have a lot of angry guys who don't have a diagnosis, and that's where they end up. We've also got guys with enduring personality change following catastrophe, F62.0, ICD-10. I've got guys who live in the woods, and they meet one of our CPNs under the oak tree every first Wednesday of the month. And some of these guys have done well on this anger management program. So this is our published material, I think 172 patients. Basically what we found is a significant reduction in anger and aggression, but also some reduction in PTSD, depression and anxiety. This anger management program for the guys going on through treatment for PTSD would be placed before they did their trauma-focused work. This is a study we conducted on our in one of the sites of our alcohol and substance misuse case management. And this is a comparison between about 6,000 civilians versus around 600 veterans who present to an accident and emergency department at Portsmouth District General Hospital. And the comparison goes something like this, that veterans actually present much later on in their alcoholic histories. They have many more physical disorders related to alcoholism, and they are admitted to NHS beds for a much longer period of 1.5 times at least compared to their civilian counterparts. So from a health economic point of view, it's definitely worth pursuing a case management approach to veterans to make sure they are assertively helped in relation to their alcohol and substance misuse. And I think that's a really important finding. The NHS is listening to this, and we'll talk a bit about what the NHS is trying to do now in a few minutes. So that's a pretty good, pretty nifty study. All our studies are on our website, so if you click onto our website and click our research, you'll find all the papers, you can read them. I was seeing a lot of guys with moderate brain injury in clinic, and I thought, well, actually, historically, brain injury was an exclusion criteria for combat stress because we didn't have a brain injury service, nor did I have the expertise to treat brain injury. Certainly, you need kind of expert psychologists, neuropsychologists involved. So we conducted a study with the Brain Injury Rehab Trust, which is another charity, very eminent charity in brain injury in the UK. And by the way, brain injuries in the UK are very poorly managed in terms of rehabilitation. The NHS is not good at this at all. And bearing in mind that the MTBI literature in the UK, as some of you will know, we're not keen on MTBI at all in the UK. The study people quote would be the contemporaneous recording in theatre recording of lower rates, and this is Jones et al. So this was a study that Norman Jones conducted in Afghanistan. He looked at the clinical histories and the operational histories of guys who allegedly had been exposed to blast, and he found that only maybe 3% had MTBI, as opposed to much higher rates, for example, in US studies. So in Britain, MTBI is not taken very seriously. In fact, there was only a program for serving personnel if you'd been through our rehab hospital at Headley Court. If you had not been through Headley Court, you wouldn't even be assessed, even if you had a history of being blown up. Well, what we found actually is we had a very high rate, 68% of our help seekers with some kind of hint that they probably had an MTBI. Now, I don't know where that leaves us because we didn't look at this as a predictor for treatment outcome, but we're going to. I know we've collected a lot more data in relation to our needs study, which we will publish quite soon, hopefully in the next 6 months, which is being analysed now. About half of it relates to sports injuries and half of it relates to operations. Of course, this is all retrospective. There's no proof of any of this, but it really is quite relevant and quite important. I mean, I'm not really keen on epidemiology. That's interesting, but I'm keen on help seekers. These are the guys who are going to turn up for help. And I'd really like to know that if guys have brain injury issues, that there is a proper service for them. So we have set up a pilot of community brain injury link workers, which hasn't quite worked. So we're looking at what is it that we can do for guys who have a significant brain injury that impairs their function. So we're looking into that, and we're doing some more research with Kent University. So just to kind of go through a bit of the research that's still ongoing, we're looking at a 2-year project funded by the British Legion into military partners. We're into stage 2 now, looking at a feasibility study. We've started some groups in the community, and this is what they are. Understanding PTSD and anger, communications, what you'd expect. And we're evaluating this, and then we will ask for more funding, probably to set up a service, an education service across the UK for military partners, or else if we can't do it, we'll ask a partner charity to do it. So I think it's really important that we investigate this thoroughly. We've done we're halfway through a project looking at cognitive processing therapy as a evidence-based process to treat veterans, particularly who live out in the sticks. Very difficult for them to access clinics. And much to our amazement, really, even very ill veterans like this, engage in it, and have completed treatment. And the outcomes, I know, are pretty favorable. So this has something in it, and I'm sure you do a lot of telemedicine in Australia because you're much bigger than we are in the UK. But it was quite a good learning project for us. We've also submitted a paper, and I'm not sure whether it's accepted yet. I think it was on the final draft, looking at our assessment process and our psychomets. We found actually that our impactive events scale revised cutoff score is 46, and nothing like the 33 that Mark Creamer et al. Kind of found. So it's useful to do these studies if you're looking after a particular population. I mean, the last time I did this study was 1994 in a British military population, and the cutoffs are always slightly different. And it's quite important to calibrate what you're doing, and that way you have more confidence to cut away some of your psychometric testing and be more kind of dependent on what you've actually identified as being more accurate. With brain injury, sorry the print's so small, we are looking at neurovestibular stimulation, a project with Kent University and I think it's Harvard University in America, to see whether or not we could kind of find any markers for TBI and or PTSD. I don't quite know how that works, and we're kind of still working on it. So where will we be in 5 years? Well, we probably will have peer support unless somebody wants to fund it and take it off our hands. I don't see it as being a clinical, quite in the clinical sphere. I'd like the veterans to deal with it, to manage it. It needs to be supervised. People do need to be trained. The helpline's really useful. I think one year we had over 17,000 calls. And there's a lot of good work that goes on there. By the way, people who are still serving and their families can actually call our helpline as well, and that's been pretty useful. We will carry on with telephone triage. That's probably one of the better things we've done in relation to our front end. It's better to identify people early on who are going to be appropriate or inappropriate for your service, and also to help them deal with their problems right away, especially if you have a prompt multidisciplinary team meeting with care planning right away. Our community service will grow. There's no question that is badly needed. We need more clinicians in the community, unless the NHS does what it says it's probably going to do, but I don't know whether they'll actually deliver. And we'll talk a bit about the NHS in a minute. So if they can do it, that's great. If they won't do it, then we'll have to. Oops, that's bad. Hang on. The OT workshops, there's a whole program. There are 7 workshops which run once a week for a whole day over 7 weeks. We're going to look at the outcomes quite soon, and we'll share that. We'll publish that and share it. And then we have a new program that will supersede our transdiagnostic program and stabilization program. It's shorter. It's being trialed at the moment in a residential setting, but it will be kind of then dished out to the community, so we can do a lot more community work. The worry I have about community is that I don't think we'll have as good engagement and completion as we have if you bring people in who really don't want to get better into a treatment center where it's very calm, they're very well supported, they will complete your program. But if they're coming once a week or 2 or 3 times a week, I wonder how big the dropouts will be, and maybe I can discuss this with with you guys because I know you have modular, what I'm calling modular intensive treatment programs to go into the community, which is really what we're working on now. We'll have a carers and spouses program, and our residential beds, we will be decreasing our beds. That's inevitable, I think. Not just because of finance, because I think it's probably right to try and get as many services as close as possible to where veterans live and not admit people. You know, when you admit somebody to a bed, you're giving him a message saying, you're so ill, you've got to come into a bed. Blimey, that's bad. That will create dependency in some. Okay. What I haven't brought is a slide on the National Health Service. So what has the NHS done? Well, it's been very mixed. So in Northern Ireland, they do very little because they want to help both sides of the divide. They don't give us any funding either. In Wales, Jonathan Bisson's team have 6 services that look after each Welsh region. There are 2 clinical staff in each team. They do outpatient work. There are, unfortunately, long waiting lists. And if anyone's really very difficult, they'll send them to our intensive program, and charity will pay for that treatment. In Scotland, we work very closely with the Scottish government. It's the easiest government really to deal with. It's not very top-heavy. They have walk-in centres, which they call Veterans First Point. You can get welfare, but you can also get mentoring or mental health intervention. But they commission us to do a lot of our programs, our residential programs, and some of our community work as well, and that's really good. For the Highlands, we're about to commission a bus clinic where we'll go up and down to the top of Scotland, and I think that will hopefully work quite well. NHS England gave me a lot of money to run the 6-week program. In fact, I applied for National Specialist Commissioning, which is the kind of commissioning is very difficult to get. If you have 400 people in England who have a particular disease and there's only 1 or 2 centres that are able to treat that disease, you can apply for National Specialist Commissioning. So we were the first charity, certainly for mental health, to get National Specialist Commissioning, and that was a lot of money. It was about £25 million. But that service now is going to be recommissioned at this point, and I advise the NHS that actually you need a mix of residential. For some of the guys won't do well in any kind of sphere if they're just treated in the community. So residential and community, they're only going to fund community interventions on a modular ITP, and it's being retendered at the moment. So I know, I got an email yesterday that the NHS expects us, a charity, to carry on providing the same level of service free to the NHS, and I don't know where that's going to go. So to come back to combat stress, we might have quite a big campaign here in the media, and I'm not scared of the media. We're not scared to say, actually, these are your veterans. You must treat them properly. I mean, I joined the Air Force as a medical student from Malta. I was on a student visa, so when I left the military, they said to me, actually, you are exempt from all immigration law, and you're back on your student visa, we're going to deport you. So my transition was terrible. And I feel that Britain doesn't treat its veterans properly. That's all changed. I mean, now there are means that don't get people deported, and I wasn't deported because I made a fuss, and Surgeon General said to me, Walter, go and cause trouble outside, but we're glad you're going from the Air Force. The problem is, I think, veterans come and go, wars come and go, and between wars everybody forgets that veterans will present with post-traumatic stress and other conditions, and nobody really will be there to treat them unless there's a champion around to do it. So thanks very much. That's it.